Now we are going to divide into two halls. Will be the diabetes hall, and hall B will be the endocrine. And I think we'll start with Dr. Jehan. Yes.
Assalamu alaikum. Good morning, everybody. We are taking you for the second lectures today and the journey of second day of BDER. I may present Dr. Jehan Abdullah. She's consultant endocrinologist at BDF Hospital, and she will present to you about a lecture, when to treat hyperlipidemia and diabetes. Dr. Jehan, please.
Good morning, ladies and gentlemen. I'm going to talk today, as Dr. Hussein said, about dyslipidemia and diabetes, when to treat. Type 2 diabetes is a major and independent risk factor for both micro and macrovascular complications. By diabetic patients, they may have another risk factors for atherosclerotic cardiovascular disease. Like what? For example, obesity. Insulin resistance is very important. Dyslipidemia is a very significant risk factor. Endothelial dysfunction, thank you. Hypertension, age, they are all risk factors related to, they increase the risk of atherosclerosis. Diabetic dyslipidemia pathophysiology, the main issue here is that insulin resistance will increase the production of VLDL, intermediate DL, and will increase the production of small, dense LDL, which is very atherogenic. And this will increase, of course, the risk of atherosclerotic cardiovascular disease. So diabetic dyslipidemia characterized by elevated triglyceride levels, low high density HDL, cholesterol level, and increase in LDL and small dense LDL. So how to prevent atherosclerotic cardiovascular disease? You need to assess the total cardiovascular risk. You need to assess the risk factors. You need to assess the lab parameters, identify the risk category. And then for therapeutic options, you need to identify the target, lifestyle therapy, and evidence-based pharmacotherapy. What risk score you want to use? There are many of them available, but you need a risk calculators and a score. You can use whatever, it's like Birmingham score or SAS score, whatever do you think is more suitable for your patient. There are many of them here, like cardiovascular risk calculator, heart score, any of them. After you calculate the risk score, then you go to risk categories. You have very high risk, for example, like for the patients with the previous acute coronary syndrome, like MI or unstable angina, coronary vascularization, stroke, TIA, diabetic with target organ damage or 3 major risk factors, type 1 diabetes with very long duration of more than 20 years, severe CKD, or calculated score more than or equal to 10%, family history of atherosclerotic cardiovascular disease. High risk score, there are patients with markedly elevated single RF, total cholesterol more than 8, LDL more than 4.9, type 2 diabetes without target organ damage, but duration more than 10 years. You can see in very high risk, and even in moderate risk, you can see diabetes is a major risk in all of them. Then after you decide about the risk and risk category and risk score, you go to the guidelines. We have many of them. You have the European Society of Cardiology, American Diabetes Association, American College of Cardiology. But who should receive statin? Before you start a statin, you need to try the lifestyle modification, advice to stop smoking, diet, exercise, dietary pattern. So this will help the patient even before you start with statin. But after that, follow the guideline. According to the ADA guideline, if your patient is between 40 to 75 years of age without atherosclerotic cardiovascular disease, then you can use moderate intensity statin therapy in addition to lifestyle therapy. If the patient between 20 to 39 years with additional atherosclerotic cardiovascular disease, then you can may be reasonable to initiate statin therapy in addition to lifestyle therapy. High-risk diabetes patients with multiple risk factor and age between 50 to 70, it's reasonable to use high-intensity statin therapy. If diabetic and 10-year atherosclerotic risk is of 20 or higher, it is more reasonable to add additional treatment or secondary like ezetimibe or to maximally tolerated statin therapy to reduce LDL by 50% or more. Secondary prevention, in all ages with diabetes and atherosclerotic cardiovascular disease, it's recommended to use high-intensity statin therapy, should be added to lifestyle therapy. Very high-risk patients, diabetes and atherosclerotic cardiovascular disease or LDL more than 1.8 on maximally tolerated statin, they consider adding additional LDL-lowering therapy like ezetimibe or PCSK9 inhibitor. If diabetic patients age more than 75, it is reasonable to continue on a statin treatment. If it's more than 75 but not on a statin, maybe it's reasonable to initiate a statin therapy after discussion of potential benefits and risk. This is the American Heart Association guidelines. Just to focus here on very high risk, they recommend for very high risk, a high intensity or maximally tolerated statin. If inadequate response to LDL and LDL still more than 70 milligram, you can add ezetimibe or a PCSK9 inhibitor. Guidelines recommend adding ezetimibe first. What about not a very high risk patient, age less than 75, high intensity statin first with potential add-on therapy with ezetimibe on maximally therapy or LDL still more than 70. Use moderate intensity statin if high intensity not tolerated. Age more than 75, either moderate or high intensity statin. You have many options of a statin like atorvastatin, flovastatin, any of them. What if baseline LDL less than 2? For example, if patient is the newly diagnosed diabetic with LDL less than 2, or if the patient is, if you're seeing the patient during follow-up visit and the LDL is less than 2, will you start the patient on a statin or not? There is a study called SCARS study. It's a multi-center randomized placebo-controlled trial, and the LDL for all patients will be less than or equal to 4.14 enrolled in this patient in this study. The age between 40 to 75. The intervention, they divided the patients into two groups. Some received atorvastatin, and the other group received placebo. They were looking for atherosclerotic acute coronary syndrome, revascularization, or stroke. So CARDS study, statins reduce cardiovascular disease in people with type 2 diabetes. The group who received atorvastatin, they have less cardiovascular disease. What if baseline LDL is less than 2? Will you prescribe statin for your patient? Within CARDS study, subgroups that started with lower baseline LDL still benefited to the same relative degree as the whole population. So the patients who were enrolled in this study, all of them, the LDL was less than 4.1. So there's a subgroup of them, LDL was less than 2, but they still benefited from the statin. If the person with diabetes qualifies for statin therapy based on the algorithm, use a statin regardless of the baseline LDL, and then target LDL reduction by more than 50%. So don't be deceived by normal LDL or LDL less than 2. You need to go to a risk category, you need to go to the other comorbidities, so don't underestimate LDL level, because this LDL will not take into account the non-HDL cholesterol, which might be still high. Getting to goal is possible. Expected benefit of lipid-lowering therapies, moderate intensity statin will reduce LDL by 30%, high intensity statin by 50%, high intensity with ezetimibe 65, PCSK9 inhibitor by 60%. If you look at this table, you would think that you are going towards combination treatment, because combination treatment gives better control. Like here, a high-intensity statin with ezetimibe, 65% reduction. PCSK9 with high-intensity statin, 75%. Second-line lipid-modifying medication, you have many of them. Bile acid sequestrant, I don't think any of you is using it nowadays. You have cholesterol absorption, like ezetimibe, fibrates, nicotinic acid, or PCSK9 inhibitor. Improved study, they use as secondary treatment, they use ezetimibe. So this is a randomized active control double-blind study of subjects with stabilized high-risk acute coronary syndrome. The primary objective is to evaluate the benefit of ezetimibe plus simvastatin. They call it Vytorin, we call it higher energy. This combination in comparison to simvastatin alone. You can see this in orange color with diabetes patient in comparison to placebo. Ezetimibe as add-on to statin reduced the cardiovascular events in patients with acute coronary syndrome and diabetic patients. So it's whether diabetic or non-diabetic, but you can see it very clear that a group who received ezetimibe with a statin, they have reduced cardiovascular event. This was in 2014, but what happened in 2018, there is another study or follow-up refining the decision to use ezetimibe results of an improve it. It's a re-analysis to the previous to improve it study, and this was in 2018, and they found the same that even among the group diabetic patients, still after even 4 years, the subgroup analysis of 27% of patients in improve it study with baseline of diabetes, the group who received ezetimibe with a statin, still they have less cardiovascular events. 4-year study. In this study, they have compared the group who received evolocumab add-on to statin with the other group who received placebo. And you can see in patients with diabetes at baseline, the group who received evolocumab with a statin, they have better, less cardiovascular stroke or hospitalized for unstable angina risk. So the relative risk reduction by 14.4%. Okay, this is about LDL. What about triglycerides? For most patients with diabetes, the first priority of dyslipidemia therapy is to lower LDL cholesterol and to target LDL around 2.6. Although the data are not definitive, consideration should be given to similar lipid-lowering goals in type 1 diabetes and type 2 diabetes. But what if your triglyceride at the time of diagnosis or during follow-up clinic, triglyceride is more than 10? Use fibrate to reduce the risk of pancreatitis. More than 10, there is high risk of pancreatitis. So they trying to reduce it to avoid pancreatitis, optimize glycemic control, implement healthy behavior interventions like weight loss, dietary strategies, and alcohol reduction. Drug classes used to treat hypertriglyceridemia, we have options. You can use a statin, fibrase, omega-3, or niacin, and you can see omega-3 reduce hypertriglyceridemia by 27 to 45%. Fibrate starting dose or range, you can use fenofibrate, gemfibrozil, fibrinotic acid. Primarily, they will reduce the triglyceride by 20 to 35%, increase HDL by 6 to 18% by stimulating lipoprotein lipase activity. And fenofibrate may reduce total cholesterol and LDL by 20 to 25%. Can we prescribe statin with fibrates? Actually, I have a patient, I referred her to the health center because we don't have fenofibrate, to take fenofibrate from the health center, and they refused because according to the doctor there, you cannot prescribe, she was on atorvastatin, you cannot prescribe atorvastatin with fenofibrate, it's contraindicated. And we'll see now if it is contraindicated or not. In this accordion study, it's a follow-up of accord patients. They use simvastatin with fenofibrate, reduced risk of major cardiovascular events in dyslipidemia patients with type 2 diabetes. And you can see the group who received, it's in this one in a blue color, who received the combination of fenofibrate with simvastatin, they have about 27% risk reduction. What about atorvastatin with fenofibrate? It improved all lipid parameters, not just LDL or triglyceride. It improved all lipid parameters, and this is a study include 120 patients with type 2 diabetes and no coronary heart disease. So the patient or the group who received the combination, they have better cholesterol lipid parameters, so it's not contraindicated. Safety of statin fibrate combination. According to the guidelines, for the management of dyslipidemia, lipid modification to reduce cardiovascular risk. Combination of a statin with gemfibrozil enhances the risk of myopathy. I can understand that some physicians, they'll be very scared to combine statin with fibrates because they are thinking about rhabdomyolysis or myopathy. Yes, if you combine gemfibrozil, according to the guidelines, it enhances the risk of myopathy, and its association with statins must be avoided. But there is no very little increased risk of myopathy when combining statins with other fibrates, such as fenofibrate. What about omega-3? Can we use omega-3? Omega-3, which is EPA, DHA, or the icosapent EPA, they help to reduce the triglyceride by 27 to 45%, total cholesterol by 7%, VLDL 20%, apolipoprotein 4%, and non-HDL 8 to 17% in individuals with severe hypertriglyceridemia, most likely by reducing hepatic VLDL triglyceride synthesis, secretion, and enhanced triglyceride clearance. But you need to keep some points into consideration before you prescribe omega-3 for your patient. Omega-3 can increase LDL, may prolong bleeding time, particularly in patients receiving other drugs affecting the coagulation, monitor ALT and AST levels periodically during treatment in patients with hepatic impairment. Some patients may experience increase in ALT. Exercise caution in patients with hypersensitivity to fish or shellfish. In patients with paroxysmal atrial fibrillation or persistent atrial fibrillation, therapy with omega-3 may be associated with increased frequency of symptomatic AFib or flutter, so especially within the first 2 to 3 months of initiation. And according to the ACE, in 2017, dietary fish oil supplements are not FDA approved for the treatment of hypertriglyceridemia and generally not recommended for this purpose. Does that mean we don't prescribe omega-3 for our patient? Of course not, because patients who receive omega-3 with a statin, they have improvement in their lipid parameters. And you can see in this study, omega-3 with a statin improved the triglyceride and non-HDL. So combination has a greater effect in reducing triglyceride and non-HDL. But you should keep these points into consideration. Reduces its study. This is a cardiovascular risk reduction with icosapent ethyl for hypertriglyceridemia. The aim of this study is to assess the effect of icosapent ethyl in patients with elevated triglycerides on ischemic event. And the result of this study is that among patients with elevated triglyceride level, despite the use of a statin, the risk of ischemic events was significantly lower with the use of icosapent compared with placebo. So icosapent with a statin give better reduction. So how to treat patients with elevated triglyceride? First, you should define the LDL goal. Then define non-HDL goal, exclude, treat, or secondary causes of hypertriglyceridemia, implement lifestyle changes. Then non-HDL goal, if it's still not achieved and still triglyceride elevated, then you think about two things. Is it less than 10? Is it less than 885.7 milligram or more? If it is less than 10 millimole, still there is a high cardiovascular risk. So what you can do is you look, the primary goal will be cardiovascular risk reduction, depending on overall cardiovascular risk, evaluate for further HDL reduction, consider further LDL reduction, consider fibrate or omega-3. But what if it is more than 10? Then the primary goal will be to prevent pancreatitis. So further triglyceride reduction required intensify lifestyle changes, consider omega-3, consider MCT fat, or consider lipid clinic. What is the effect of diabetic treatment on lipid profile? I don't know if you have ever thought about it. If when you prescribe SGLT2 inhibitors or metformin or sulfonylurea to your patient, do you think they have any effect on LDL or lipid profile, the patient's lipid profile? We'll see this here. This is just, this table summarizes everything. Biguanide, metformin, it will increase HDL, neutral and decrease LDL. For total cholesterol will decrease total cholesterol. For triglyceride will decrease triglyceride. You can see here most of them except sulfonylurea will reduce or neutral effect on LDL and triglyceride. So dyslipidemia checklist before, at the beginning, even at the time of diagnosis, please, you have to check the lipid profile of the patient, and you can have it as a baseline. Check lipid profile at diagnosis, then yearly or every 3 to 6 months. Use statin as a first-line therapy. Add second-line agent only when LDL is not at the target. Use fibrates when triglyceride more than 10. The beneficial effect of lowering LDL with statin therapy apply equally well to people with diabetes as to those without diabetes. The primary treatment goal of people with diabetes is LDL less than 2 or 50% reduction from the baseline. Alternative targets like non-HDL apolipoprotein B less than 0.8. What about fatty liver? It's very common in diabetic patients. Non-alcoholic hepatic steatosis is not a contraindication. Hepatic function test should be obtained at baseline at 6 and 12 weeks. If aminotransferases remain greater than 3 times the upper limit of normal, then you should consider changing to a different statin and identify other contributing conditions or drugs. Statins are contraindicated in pregnancy and breastfeeding and in patients with significant hepatic dysfunction. So the take-home messages: people with type 2 diabetes have a substantially increased risk of cardiovascular disease. This is largely related to a diabetic dyslipidemia, which results in more atherogenic lipid profile. Diabetic dyslipidemia is a modifiable risk factor. Optimal lipid management, therefore, a key component in a multifactorial approach for preventing cardiovascular disease and cardiovascular events. Statin, ezetimibe, and PCSK9 inhibitors have proven efficacy in patients with diabetes, and they have been shown to lower cholesterol levels and reduce cardiovascular mortality and morbidity. Statins represent the current cornerstone of lipid-lowering statin, but still we have ezetimibe, PCSK9 inhibitors are additional options when statins are not tolerated or fail to adequately lower cholesterol level. People with diabetes with coronary heart disease respond to statin in similar manner to their counterpart without diabetes. They experience highly significant benefit in terms of reduced incidence of major vascular event. Thank you.